And now we are going to move to our third initiative, Raising Washington, presented by Jurgen Unutzer. And Dr. Unutzer is a professor and chair in the University of Washington's Department of Psychiatry and Behavioral Sciences. Now, we've seen him before, but we did get to hear his whole resume, which is very impressive. He also directs the Garvey Institute for Brain Health Solutions and holds adjunct appointments as professor in health systems and population health and global health. As an internationally recognized psychiatrist and health services researcher, his work focuses on innovative models of care that integrate mental health and general health services, and on translating evidence-based mental health care into effective clinical and public health practice. So, Dr. Unutzer, there we are.
Well, thank you for the nice introduction. Thanks again for the opportunity to talk with you all today. I think I'm the thing that's standing in between you and lunch. So let's make sure we'll keep on time. Who's going to help me with time? Excellent. All right. Very good. Okay. So so my day job is I'm a psychiatrist. I chair the Department of Psychiatry and Behavioral Sciences here at UW. And in my day job, I get to work with some really amazing people. And I find myself spending a lot of my time supporting, training, helping people who are taking care of individuals and families across the age spectrum who are struggling with mental health and addiction problems. And that's really important work. And it's actually really hard right now with all the chaos we have at the federal government, at the federal level, and the challenges we are having in our state with our state finances. But today I'm going to talk about something a little bit different. We heard in the presentation right before us the word proactive. I'm going to talk about this idea that maybe we should move the stuff, some of what we do, way further upstream. You know, what is it if we wanted to improve your mental health before you're even born? And I'm very appreciative for Brittany Weiner and Molly Firth, who actually set this up a little bit, gave us a reason for why we should be thinking about this stuff early on when we're thinking about maternal health. And I'm going to present this idea of what if we had a really great partnership to help move mental health upstream as far as we can. And I hope that in a couple years, we get to come back here and present as one of these initiatives that actually really did that. I think that's my goal. So I'm going to go kind of quick on making the case for this. What I will say is there are about 85,000 people born in the state of Washington every year. And we could I'm pretty sure we could all agree there is a good number, maybe about 10,000 of these births where we could all agree this is a kind of a high-risk situation. You know, and what is the risk? The risk could be, a mother or a family that's in a lot of distress. Maybe there is a mental health disorder, maybe substance use, maybe domestic violence, other kind of risk factors where we would all say, wow, this is kind of a high-risk situation. So that's the problem. And before I go to the solution, I'll tell you a little story. So there's a picture of a lady on here. This is Dr. Gro Brundtland. Gro is a very interesting woman who I had a chance to meet and have influenced me early on in my career. She is a family physician from Norway. She was also the Prime Minister of Norway for 3 consecutive terms. And after she did that, she became the Director General of the World Health Organization, and I had opportunity to do some work at the World Health Organization, and at some point they didn't have a lot going on at the time in mental health, and I was kind of not an intern, but not that much further in my career, and she sort of challenged me, and she said, why the heck would we do mental health? We are about infectious diseases and all kinds of other things in the World Health Organization. And she said to me, what if you only had $1 to do something for mental health? What would you do? And I thought about it, and I said, what I have on this slide here, I would use it to help a mother struggling with depression or substance use during pregnancy. And she looked at me like, what are you talking about? You're not talking about schizophrenia. You're not talking about bipolar disorder. What I didn't know is she had, and this is very sad, she had a son who had bipolar disorder who committed suicide. She told me that after we had this conversation. But anyway, so she challenged me, said, why would you do that? So I launched into I'm a good academic. I launched into a long spiel about all the risks of struggling with a mental health or addiction problem when you're pregnant. And there are problems that are common. I think we heard earlier, 1 in 5, anxiety, depression, substance use, these are common. There are problems that are rare but very serious. People who develop real serious postpartum psychosis or obsessive compulsive disorder as part of being pregnant. And then, we heard earlier, this is now, and this is super sad, this wasn't always the case, this is now the #1 driver for maternal death in our state. And the risk factors, having a history, living with a mental health or addiction problem, and a whole host of stressful life events, we can all imagine that those are things that create risk. Interestingly, these are things that can affect us today, but we can also transmit that risk from generation to generation, and we can do that by passing on our genes. We can do that by creating an experience the first 9 months that you're spending in utero, where you're exposed to very high levels of stress hormones. Somebody who is anxious and depressed all the time has a tremendous amount of stress hormones, or somebody is taking alcohol and drugs. Those are things that affect that tiny little baby's brain as it's developing, and now you have a baby that's born that has a different brain because of these exposures early on. And you might have now a baby that's a really fussy and hard to console baby, and you have a mother who is very stressed out and maybe overwhelmed. And what happens after birth is what that baby most benefits from, which is to kind of be born into a world where you learn very early on, the world is a safe place, it's a good place. When I need something, I get my needs met. And you develop something that we call in psychology secure attachment. And this is interesting. So the World Health Organization hadn't done much in mental health, but I ran across this report from a British psychiatrist named John Bowlby. He's one of the persons who developed something called attachment theory. And he actually wrote a report commissioned by the World Health Organization in 1950 that talked about the importance of healthy attachment. And he talked about, for example, the importance of a warm, continuous relationship between a child and their mother or a mother figure. And he said that the absence of maternal love has damaging consequences for a child's emotional health. And that makes sense to most of us, but that's what's very hard to do when you're in a high-risk, super stressful situation. How do you do that for yourself, for your child? How do we do that as a family who's struggling? So I went on to talk more about the risks of untreated mental health or addiction problems. And then she said, well, okay, that's all really good, but do we know anything about what to help? And I said, actually, there's a lot we know how to help. We can screen people in primary care or in prenatal care. We can screen after birth in a pediatrician's office, in somewhere where we're caring for somebody. And it's not a no-brainer. It's not always easy. So if I'm a pediatrician, I'm not a pediatrician. I have wonderful colleagues in pediatrics that we will work with on this initiative. But when you're a pediatrician, your client brings a child in for care, and it's not that easy to say, hey, by the way, maybe I'm a little concerned. Your baby seems okay, but I think you might be having a mental illness, and I don't really have all that much to offer you. For that. That's a tough conversation to have. I know you wouldn't do it like that, but that's essentially what you have to say. That's not easy. There is a ton of things we can do along the lines of social support groups, thinking about healthy eating, managing stress, parent training, parent support. There is formal psychotherapy, and there are medications that can be helpful. And that's all really great, except for most women, most young families who are in one of these high-risk situations really don't get any effective mental health care. So that's the gap we have. Now, about a decade ago, we had a really neat opportunity. We developed a partnership with King County Public Health, and we were working in about a dozen community health clinics around King County that were offering care, prenatal care, peripartum care to women, and we identified about 2,000 women who were getting care in one of these settings who were struggling with depression. And what we did is we implemented a really nice program where we resource the clinics to provide some really good high-quality depression care along with their perinatal, peripartum care. And what we found is, and this is my one data slide, so we studied these women, and what we did is we studied women before we implemented this program. Those are the women who are summarized here in this blue line. And then we studied women after we implemented this making good depression care available in the primary care setting where they were in the community health clinics where they were getting their peripartum care. And what we found is that the women who were depressed before we implemented this program, this is what's called a survival analysis. It took about almost a year for about half of these women to have a significant improvement in their depression. And after we implemented this program, where we started providing better depression care, we shifted this curve way over to the left. So now we're talking about 8, 9, 10 weeks, and half of the women are no longer depressed. That's a huge difference if you're going to spend the majority of your time during your pregnancy being seriously depressed. So we know that this can be done. We know it works. And so what we are proposing is a really ambitious partnership to provide truly comprehensive perinatal mental health and parenting support for the first 1,000 days of a child's life. And that's starting from peripartum all the way through the child's second birthday. That's a really critical period early on in development, and that's what we hope to see happen. And we would start that as a partnership. And we would start here at UW with psychiatry and behavioral sciences, with our colleagues in obstetrics and gynecology, in pediatrics. I think Dr. Walker Harding, who's my counterpart in the pediatrics department, is here. And we're super excited to partnering with colleagues in pediatrics and family medicines in our UW School of Nursing and social work, and then to go out and find other local regional partners who really want to help join us in providing that kind of a strong integrated support. And additional partners could be Washington State Healthcare Authority, state and county health and public health agencies, community-based midwifery services, somebody mentioned earlier, birth doula services, home visiting programs. There's a lot of energy, a lot of people who care about this population, but a lot of it isn't really coming together. And many of the women and the young families who could benefit from having that kind of support often don't really know about it. So that's one thing we would like to see. And so the vision would be that early on, we're going to set out and identify a number of executive sponsors, people who are going to commit with me to say, yes, we're going to commit our organizations to really build a strong partnership to really make something like this happen. We will develop a project management team, a group of really good clinicians who can put their heads together and say, what would that look like if we had a comprehensive offering for this group of high-risk individuals? We're going to go out and look at a whole bunch of programs. We're not the only ones who've ever thought about this. There are good things done locally already. There are good things done regionally, and there are some really interesting global programs. I have a good colleague in Pakistan who does an amazing program with community health workers going into parents' homes, into patients' homes, and doing some really amazing stuff with not all that much money. We would then like to engage with relevant local and regional support services and resources and really develop and pilot test a strong perinatal support program that wraps around a person like this. And we would test that with about 100 women who are coming to UW Medicine to have a childbirth. If that looks like it's promising, we would like to build on that. We would like to then say, what's the next step? We need to make sure that we actually are making a difference with this. So we would like to do a randomized controlled trial where we're offering women to participate in a randomized controlled trial where they're either getting this kind of enhanced integrated perinatal mental health support, or they're getting all the care we can currently offer. So that's care as usual. And if that's successful, we would love to go statewide. We would love to partner with the healthcare authority, with other partners across the state. We'd like to develop training programs because these are not things that all of us are good at doing right now. We'd like to make sure we have good training available for people across the state to provide these kinds of services. And our next steps will be, we're at the beginning of this. We're going to want to convene a good leadership team. I have my colleagues here from UW Advancement across the different schools, not just one department, one school, because I think this really does require a partnership to help us with going out and finding some funding for this. We're going to establish a really great project management team, a clinical leadership team, and a really nice community advisory board that helps us with this initial phase of the work. My long-term vision is we really are going to figure out how to go upstream. We're going to become the healthiest state in the nation to have a baby. We will become, that's the vision. We will become experts in training future professionals in how to do this, how do we support parents and families in a high-risk situation like this. And my hope is that this is going to be an investment that's so great where people around the world will say, yeah, that $1 spent in this way really could make a huge difference. With that, what can you do? How can you get involved? Participate in our community advisory board. You can join us in helping us with project management, with providing clinical and social services. Some of you are on the front lines. You're working with individuals like this. Let's figure out what it takes to really provide good care for people who are struggling with depression, with substance use, with other problems, and how do we bring it all together? You can engage as a community partner, or you can think of other organizations that are already doing really meaningful work in this area and saying, can we join, can we work together on this? You can help us share this opportunity, this idea with other people, and you can help us raise funds because I think Malka Dingra said this morning, people cost money. Helping people costs money. This is going to cost money. I have no doubt about that. And I'm not going to be shy about that. We're going to, if we want to really convince ourselves and others that this could make a difference, I think we're going to need to raise quite a bit of money to try to help make this successful. I'm up here sharing this idea. There are a lot of smart people that have helped me think about it. I hope there'll be a lot more smart people that'll come together. We have a project manager, a program manager for this initiative, Lori Farrow. Is Lori here? Lori is over there. Look at her. She's waving at you. She's got a little flyer, a one-page flyer that tells you a little bit more about this initiative and what you might do to get involved. So if you find this interesting, if you'd like to join us, if you have suggestions for things we could do right or things we could do wrong or stuff that's already out there that's already doing this in a great way, please let us know. I think with that, I think we're doing okay on time. That's all I have. We have time for questions, thoughts, suggestions. Thank you. Anybody have any questions, or everybody's ready to head out for lunch? All right.
So now I'm standing between lunch and all this. My name's Tiffany. I am the other speech pathologist in the room. Hey, Jim. Thanks for presenting. So I'm here wearing my Northwest Center hat, which is a Part C or early intervention program. And I'm also a direct service provider for feeding and lactation at Seattle Children's. And I see the intersection when it goes from the birthing parent to the infant, and then those systems being disconnected, right? There's the parent system and there's the child system. There's not that dyad. And then you add the NICU families in there as well, and that developmental disability. So I don't know what my question is, except that I was trying to just stay seated and not share how excited I am, but I'm really excited about this work, and I would love to connect and make sure that NICU specifically and children with developmental disabilities and their families, we're supporting them as the whole family.
Thank you.
Thank you.
Yeah, I mean, I think this is important for everybody. This is going to be especially important for kids that we already know from the get-go we have a really high-risk situation here. And I think this is actually one of those areas where people are not turning a blind eye. People care about little kids. They care about moms. And there is actually a lot out there. It's just not coming together very nicely, right? And most people who need the help are really struggling And even just helping somebody navigate all of that stuff is already a challenge. But I think every one of us who is having an opportunity to touch somebody at some time, and it could be a lactation consultant, it could be somebody who's realizing, wow, this is probably harder than the average person I see. This is somebody who's really struggling. This is somebody really at risk. When you're that person and you're having that thought, what do you need to be able to help that person? Make sure they just don't go out and you did your thing and somebody else is going to do their thing. And we really can engage them in something that's going to be feeling like I got somebody to back me up. I got something that feels safe, that's going to help me. Parenting is really hard. I have 3 children. I'm a pretty smart, accomplished person, and that the most humbling thing you'll ever do is try to have a child and try to help that child grow into a real human being. Many of us are very privileged, and it's already hard. And so there is no question that it can be really challenging. And I do think all of the words we have about silos and about people not connecting, that's very much true in this case as well. So thank you for bringing that. Yeah.
Yeah.
Okay.
That way first.
Is it on? Okay. Hi. Because we're talking about breaking down silos, I just want to share one story that's an opportunity that I'm not hearing here. I have a friend whose son was adopted, fetal alcohol spectrum disorder, and autistic. And he was in public housing or core waiver, I'm not sure, whatever. Really difficult to stay in housing because he found a girlfriend who was homeless on the street. They ended up finding homes together, whatever. She had a baby. And now this grandmother has been calling Child Protective Services on her grandchild because there is no resource. And so we have to think about, and I'm a community member and I don't know how to help her. So we don't think just about the mother. We need to think about the father. We need to think about the community that is trying to support, because that is how that we're going to be able to really help maternal health, is really see it as a broader system that is, coming out of all these different other silos, and they're not being helped. Thank you.
Yes, I couldn't agree with you more. And I think even John Bowlby in the 1950s already, made the case that it might not be your biological mother. It's a mothering figure. It's somebody who can help you. And it could be a father, it could be a family, it could be a grandmother, it could be, any number of individuals who have feelings for that child and who we could engage with and support, right? Absolutely. Very important point. Yeah.
This one's from an audience member online. So what about parents who are struggling with infertility on their journey towards parenthood?
Yeah, that's also a really interesting point. So my first year in medical school, sorry, I'm going to tell the story now. I had opportunity, and this was in the late 1980s, had an opportunity to work in one of the first infertility clinics in North America. And I was working with a very brilliant a woman who was making it possible for people like that to have babies. And I was a first-year medical student, and I didn't have that much to add in the lab. It was kind of cool what they were doing, but I got to spend a lot of time with these families who were coming in and getting help with their infertility, and they were incredibly stressed out. Oh my God, and this doctor was really brilliant. She was a really good technician, but she wasn't very good at talking to people when they were stressed out, and it turned out I was kind of good at that, and I'd sit there for a long time, talking to them about what journey they had gone through to try to get pregnant, and then what is it going to be if it doesn't work, and so on. And the lady said to me at the end of the summer, "You were pretty good in the lab, but maybe you should go into psychiatry. You're really good talking to these people." So I'm sorry, maybe that was a little bit of a tangent, but I think it's very important. That's also a high-risk situation. It can be very, very difficult and challenging and stressful. And I think that's another great way to try to engage and say, do these people need more than, a fertilized egg? What else do they need to really, to thrive as a family? Yeah. Sorry.
That's okay. You go ahead.
Okay. I just wanted to share, I used to work in the PCAP program, the Parent-Child Assistance Program,
Yes.
if you're familiar, and it is an absolutely wonderful model that has been very successful across Washington. It sounds like you're familiar, but I just wanted to, I know that sometimes different branches of the same agency and university don't talk as much, but they would be a wealth of information about how to do this type of long, several years intervention with high-risk mothers and children.
Yes, it's a wonderful program, PCAP. It's actually in our department as part of ADAI, and it's a fabulous program working with mothers who are struggling with substance use, working with mothers in recovery, and I think we can learn a lot from what they've done. So thank you for mentioning that. Yes?
We have another online question. So how much money will it take to provide good mental health care to every new parent in Washington? Or what is the sustainability plan?
Let's take a wild guess. So just think of, it's a great question, right? And I'm not going to repeat it because I think you said it on the mic, but what do we think it would cost? Let's say we have 10,000 of these situations a year in the state of Washington. And what do we guess it would cost on average to provide really good, wraparound, good perinatal mental health support services all the way through the first 2 years of a child's life? Let's see, those of you who are thinking about healthcare and money, what are your thoughts? Anybody want to throw out a number? Yes? 20,000, you said. Okay. Anybody else want to throw out anything? Somebody's going for 100,000. Okay. Maybe you should get Todd up here. He's good at doing the auctioning thing. Todd is giving us 110. Other thoughts? Okay, it could be maybe 20. It could be 100. We don't really know. I think this is one of the things we're going to learn. And the way I think about this is not everybody needs this. This is the kind of thing I think we ought to bundle into, a bundle for, what it takes to have a healthy delivery of a child that's supported by Medicaid in this state. We need to figure out how to do it well, how to do it, at a reasonable cost. And then I think it ought to just be bundled in. We ought to be able to say, you can't leave the hospital if you don't have a child seat. I think we should also say, as part of going through the whole experience of giving birth, if we identify and you identify that you're in a high-risk situation, $20,000 is not a lot of money, to be honest, because it'll spread out over a large population, and the downstream benefits of having the right things go right in the first 2 years of life are really tremendous. But that is partly why I think we do need to do a study on this. I don't think we can just do it and say, just believe me. So I think once we have a successful pilot, I'm actually going to make a strong case that we should actually see how do we do it, how much does it cost, how do we do it at the right price. But that's a great question, so thank you for that. Okay, other thoughts, questions?
Yeah, one person online is wondering, is there a telehealth option, or is this going to only be in person?
No, I think as with everything, we'd probably have to think about what are the things you can do best in person when you're connecting with a human being. And there is a lot of in-person connections, actually, in this situation early on. You're seeing a doctor or a healthcare professional, maybe a midwife, maybe a doula. You might be seeing a lactation consultant. A lot of those things still are happening with people looking each other in the eyes. And every one of those is an opportunity, I think, to engage. But then there are going to be services where I'm quite sure once you have established a connection, it's going to be a lot easier to stay in touch, by telehealth. You can reach out to anybody by texting, by telehealth, and I think we just got to explore all of the different modalities that we could use to see what's the best way to really support somebody. Sometimes text-based communications can be incredibly effective. I'm familiar with a program in Pakistan and a program in Africa where they're texting with women postpartum, to help with postpartum depression, to help with other things. And when you get real-time support at the time that you need it through a text message, it can actually be super successful. So I wouldn't put any limits on, is it going to be in-person or telehealth? Those are all things I think we have to figure out. Okay. One more?
Online. So how will this program support the unique needs of transgender and gender expansive gestational and non-biological parents?
That's a really great question. I I think I'd be really shooting from the hip if I tried to answer that from this stage, but whoever asked that question, I would love to invite you to join us to help think about that, right? Those are really, really important things because those are unique challenges, and I think we should try to step up and figure out how to best do that. But I think it wouldn't be really smart for me to try to just make up something. I acknowledge that it's really important. It's another challenge that we need to try to meet in a thoughtful way. And so anybody who has an interest in that, join us. Okay?
We have one more question, then we're done.
Thank you. It's more of a comment and a plug.
Okay. Comment.
My name is Julia Kemner. I'm with Behavioral Health Catalyst, and we provide support in the development of the statewide strategic planning effort that's underway right now for prenatal through age 25 behavioral health. It's called Washington Thriving, and if you're not already involved, its core questions to be answered are specifically around how we sustainably finance our behavioral health and create a system of care that is clearly defined, envisioned, while reducing all of the system complexity that we are facing, particularly in Washington State. So if you want to get involved in providing input to those conversations, if you have ideas about financing or any other part of the P to 25 system of care, please visit washingtonthriving.org. We are currently soliciting as much feedback as possible to inform the development of the plan, which will be delivered to the legislature in November. So this is the time to share your voice and your stories. So thank you.
Thank you. Yeah, thanks for Behavioral Health Catalyst and for that effort. Yeah, and again, thank you all for any thoughts, any input, any criticisms you have early on. I really do hope that there'll come a time where we're back here and we're going to say we did it. We're the best state in the nation to try to do this kind of thing. And thank you all. Early on, I think we are going to look to our colleagues for philanthropic support for this. I think there'll be a later stage where I think at some point our federal government, this is my hope, is going to come to a consensus, and we need to do a big study that's going to require some federal dollars to do this. And when that time is right, this is something that I think we can have the state put tax dollars behind. But I think just one thing at a time. But thank you very much.
Thank you, Dr. Unutzer. It's a privilege to have you here to share your depth of knowledge and your expertise and inspiring us with a vision that we can absolutely follow. So we are going to invite you all to enjoy the lunches provided at the table, and more importantly, to wander into the exhibit halls. We have them, north, south, and inside the ballroom. We have a variety of organizations that we'd really love for you to take a look at, learn about some of our sponsors, as well as some of our excellent state-funded programs. They're also here, and you can ask some questions and learn more about them. There's only room and time for 6 initiative presentations here at this summit, but these exhibitors in some of these areas, we invited them here as well so you can learn from them because they have lots of ideas. As for lunch, there are 2 food lines. The line in the back of the ballroom, which is going to be over here, and they're still putting it out, has